Good afternoon, everyone. Thank you all for being here. Welcome to Office Hours on Building Resilient and Sustainable Sobering Centers in California and beyond. My name is Meryl Schulman. I am a Senior Program Officer at CHCS. My pronouns are she, her, and I will be facilitating today's event. I want to start off by thanking the California Healthcare Foundation for supporting this work, my colleagues for their work behind the scenes and pulling together today's event, and to all of you for joining us. On a logistics note, this event is being recorded, and you will receive the slides and a recording following today's session. We will also be putting together a frequently asked questions or FAQ document, and so that document will be posted to CHCS's website, and we'll go through the questions that we discuss during today's session, as well as any questions that we do not get to and that were submitted during registration. Next slide, please. I just want to share a little bit about the Center for Healthcare Strategies, or CHCS, for those who may not be familiar with us. So CHCS is a nonprofit based in New Jersey that works with stakeholders nationally to strengthen healthcare services to ensure better and more equitable outcomes, particularly for kids and adults served by Medicaid. Since 1995, we have worked in every state in the nation, and we do our work in partnership with state and federal agencies, managed care plans or health plans, providers, community-based organizations, and consumers to make healthcare work better for people who face serious barriers to well-being, like poverty, barriers to well-being. We also work to advance more effective models for care delivery, like the sobering care model that we'll be talking about today. We work to advance more efficient policy and programs. And across all of our work, we focus on more equitable care and opportunities to address the obstacles that stand in the way of health equity. Next slide, please. So here is our agenda for today. We're at welcome and introductions, but then we'll have about 10 minutes of presentation where my colleague Shannon will be sharing about sobering centers and new resources that can support the implementation of sobering centers. And then we'll have about 40 minutes or so of moderated Q&A where we will go through pre-submitted questions that folks submitted during registration. We'll also have time to take questions live, and then we'll wrap up for the day. Next slide, please. So on this slide, you can see the different ways that you can submit questions for today's speaker. So we have all of those pre-submitted questions that I mentioned earlier. You can also write in any questions using the Q&A icon located at the bottom of your Zoom screen. You can also ask your question verbally. To ask a question verbally, please use the raise hand feature, and then we'll unmute your line and you'll be able to ask your question. Lastly, if you are joining by phone, you can email questions to my colleague Amanda Bank at abank@chcs.org. And then if you have any comments or thoughts or want to converse with other participants, you're welcome to do so via the chat. Next slide, please. So you already met me, Meryl, but I'm very pleased to now turn it over to my colleague Shannon Smith Bernardin, who is the co-founder and immediate past president of the National Sobering Collaborative. Shannon is also an associate professor at the UCSF School of Nursing. She has a wealth of knowledge on developing, implementing, and sustaining sobering centers, and we're so pleased to have her and to learn from her today. Shannon, we can go to the next slide and I'll turn it over to you to share a little bit more.
Excellent. Thank you, Meryl, and thank you everyone for being here today. So for those of you I haven't met, I am Shannon Smith Bernardin. I'm a registered nurse by trade, and I got into sobering care work back in 2007 with the San Francisco Sobering Center, where I spent about 10 years. And then since then have worked on a lot of different things, from sobering care research to helping different cities and counties open programs, et cetera. So today we'll run through a few brief slides, but the main purpose being office hours, doing lots of Q&A. We could jump to the next slide. So quick overview on sobering centers in general. I know a lot of people in this room, either your community has a sobering center, you've been in discussion about trying to figure out how to start one. But to start, basically, it's a community-based alternative for individuals with acute intoxication, alcohol and or other drugs. It really varies per community on what substances of intoxication are included. And ideally, we're looking for individuals who are being diverted from other resources, the emergency department or jail, and or others who their substance use puts them at harm in the moment. So they're a danger to themselves, they're a danger to other people because they may be trying to go everything from walking into traffic to just sleeping on a sidewalk in bad weather. We want to make sure they're safe. And this is the point of sobering. It's a safe environment. Usual typical lengths of stay are a few hours long, 4 hours, 8 hours, 12 hours. And basically, we're trying to keep people out of the criminal justice system, out of emergency departments if they don't have a higher medical need. And then ideally, both in the immediate sense, diverting from those services, in the longer term sense, not having folks have a criminal justice history and need to go through the court system and losing benefits, et cetera. We can go to the next slide. When you're looking at starting a sobering center, so based on some of the things I just mentioned, there's a variety of ways that you can make a business case in your community for why you would want to put sobering care in the area. So just basic comparison, costs, timing, resources used, emergency department, jail versus sobering, keeping people out of the criminal justice system, as I mentioned. And then you can look at the system in general, so the individuals themselves who are coming to the door. Maybe there's individuals who are higher users of other services. So they're going to the emergency department a lot. They are having criminal justice engagements with officers in the street. Maybe they're being seen by a lot of the street outreach teams, et cetera. So looking at where they're touching the system in other areas and where they're not. There's a lot of individuals that would benefit from treatment, from harm reduction services, from recovery services that can never get in the door. And so how do you look at where people are in the system, how they access additional resources, and what costs are affiliated with what they're doing? And ideally looking at both short-term, the immediate, getting someone sobered up for a few hours. And when I say sobered up, to functional sobriety, somebody who is now able to take care of themselves and leave. They're not blowing zero on a blood alcohol level, like a BAC with the blood alcohol level. And then also looking at longer term benefits for the system in general, for the individuals, et cetera. Next slide. So there's a bunch of resources out there now. I will put on my other hat and do a shout out to the National Sobering Collaborative, which is a nonprofit that works with communities who have sobering centers, looking to start sobering centers. And a lot of us have come together throughout this, and a couple of us put together and worked with the California Healthcare Foundation to design and develop a blueprint overview of sobering centers in general, a lot of best practices around sobering centers, and where this tool, and this is an official shout out with the CHCS team and the California Healthcare Foundation, of an implementation guide for creating sobering in your community. And this benefit has every different area that you could consider and helpful areas for creating the sobering center, from figuring out your needs assessment to all the way through developing staffing plans. It has a financial tool, which is an Excel spreadsheet. And yes, I was part of the team that helped develop that. I am not a financial expert when it comes to that. So it really speaks to the CFOs in your community, the folks who are in charge of the treasury side of things. And then all the way through operations. What types of risk mitigation, risk management, risk assessments, what should one be doing ahead of time? What are all the different areas of consideration for who should be at the table? And so the chat just put the link into that. It's open and accessible to anyone who wants to use it. And you can feel free to reach out to myself and Dr. Jesse, who were the two who authored this. We can go to the next slide. And I'm going to feature a couple of the areas, one to explain a little bit about sobering in the room to a higher level, and also feature what's some of the things that's in this particular toolkit. When you're looking at putting sobering in your community or enhancing a program that you already have, or potentially augmenting, like you have services that are working with individuals with harmful substance use, alcohol, other drugs, et cetera, maybe you can just add something to that. Maybe you have a crisis receiving program, but they're really only receiving from mental health, not substance use. How can you augment or enhance that system? And one of the main things I'd love to point out at this point is Sobering Center is a lot of what I've described in terms of that acute moment of intoxication to reduce the harms of intoxication itself. Monitoring somebody, make sure they don't have something else that's a medical emergency going on at the same time. Making sure that they don't have alcohol poisoning, monitoring them to just make sure that their breathing stays okay, the medical side, the health side, to the idea of just putting them in a safe space. It is not detox. So we're not trying to remove all substances from someone's body over a 2 to 3 day period. We're not trying to necessarily, you can run a sobering center without any medications at all. It's helpful to have some. You don't need any because you're not necessarily caring for withdrawal, whether that's alcohol or benzos or opiate or meth. It is not a treatment program. So folks, we expect people to come in the door, sober up for a few hours and leave. That type of engagement. So just want to kind of distinguish. It's not a sober living facility. We are not anticipating people are going to walk in the door and then become sober and go to another facility from that point on. With the assessment deep dive in general, when you're considering all of that I just mentioned on what resources you have in your community, do you have other services that are already filling this role, but not to the level that you want them to? Who deals with intoxication? From the community members, et cetera, to what are existing services, gaps, et cetera. And this is the type of things you want to be thinking of when you're looking at sobering. And then also looking at the feasibility side of how many individuals are we really talking about? Not every single individual with intoxication is appropriate for a sobering center. They might have a higher level medical need. They may have other charges, for example, with law enforcement, that they have a felony charge at the same time. They're not coming to a sobering center. They're probably going to jail. That's the type of thing that you have to figure out. If only a tiny portion of the individuals with intoxication in your community might be appropriate, this will help determine that. And maybe you have another service that might be more helpful. Go on to the next slide. Who do you want to talk to? And if you're in the back of your head going, we really want to talk to this particular role in the city, but I don't want to include them yet because I'm afraid what they're going to say, start including them. Maybe not in the bigger meetings, but I promise you that if you think there's anyone in the community that may disagree with the way a sobering center is being planned, you want them at the table first. And that could be everything from the law side of it, from public defenders to the drug court judge, to the local healthcare plans, to the medical director of certain agencies. Bring people to the table right away. They'll have brilliant ideas on what they're already providing and moving on from there. And I think the most important thing is figuring out the common ground. And a lot of folks are going to be at the table and be like, we just want to save money. That's okay. Everybody wants to be as efficient as possible. Other folks who come to the table and they only care about the individuals who are coming in the door and what happens to them. That is also excellent. You can find shared overlapping goals and outcomes that would make everybody happy, but it's best to be at the table at the same time. Next slide. This is a big question. I know we're probably going to dive into it a little bit in the Q&A because someone has asked questions about this. When you're looking at planning a sobering center, what's the cost for them to go other places? But the reality is you're going to have to get a building or some facility. There's going to be a lot of startup costs. You could be a big dorm, could have a couple different dorms, but you'll need things like beds, showers, ideally. Licensing, there isn't a licensing for sobering centers themselves. That doesn't exist. And I'm going to shout out and say, I hope it never exists. We do have an accreditation program coming soon, which we can talk about later. But there's a variety of costs there. The cost to pay for staffing. Staffing is the majority of cost when it comes to sobering. It's a simple model. Sobering is not a complex entity, but there are a lot of costs regarding staffing in particular. And you want to look at who in the community is benefiting from this, where the money is going to. And then, as I mentioned, there's a financial planning tool that can help look at different scenarios. If we relieved the amount of people going to jail, that also reduces the amount of time that officers spend booking people in jail. And now we have a lot more officers who are available for the rest of the role that they have going on. Next slide. And I'm going to finish up in the next 2 minutes or so we can jump into Q&A. So when you're looking at developing a sobering center, and yes, there's a Q&A icon, and we do have some pre-submitted questions, by the way, as I mentioned, and we will be taking live also. So feel free to jump in there and say hi. With the early part of planning sobering, one individual can be a champion and just say, I want to make this happen, and get everybody else around them. And that's the early stage. What exists, what doesn't, figure it out. The next part is figure out the site. Maybe you actually are a very lucky community and you have a site already. You're like, okay, we have a bunch of other resources on a campus. We've got this available area. We can turn this into a sobering center. Other communities, it's far more difficult. I know of certain cities that it's taken nearly 4 years to find a location with the amount of NIMBYism, the not in my backyard, getting the right people at the table, finding a building that was the right size, et cetera. That really can impact how it moves forward. We have suggestions and there's ways to look at. So you can reach out anytime. And then all the stuff of putting the program together, getting policies involved, and through all of this is working with the stakeholders. Who's going to be referring to your program? And where do you ideally want your clients to go at the end of it? Those folks should be involved in all of these conversations. And then, of course, going through quality improvement. Next slide, I think. Awesome. Okay, so we are at the last 2 slides. The staffing models at work. We are going to dive into this a little bit in questions also. The ideal is to have some level of healthcare professional who can monitor for health conditions and peer professionals. And sobering is a peer professional model. It is a model that works because we have staffing of individuals who have had similar experiences, whether that is in substance use, the criminal justice system, the experiencing homelessness, if that is the population you'll be seeing, and they have levels of recovery. And when I say recovery, I do not mean abstinence. So I recommend do not require abstinence and certifications for people to prove that they have a 2-year chip, for example. And so with that health and peer level, you'll have amazing amount of ability to engage with individuals. It is 24/7. Typically, you could do a flexible staffing where maybe you don't have enough money to pay for registered nurses to be there because you want to take from ambulances, and that is a good paramedics, or RNs. But you could do something like Thursday through Saturday or Sunday would be a higher level of care to take from ambulances, and the rest of the week would be EMT basics. And then there's all kinds of other augmentation you can do. A lot of homeless individuals, maybe nurse practitioners or social workers, case managers, et cetera. And next slide. And then looking at what to evaluate for the sobering center itself. The only thing your sobering center does is take in individuals who are intoxicated to keep them from going to other services that are not the most appropriate for their care. And these individuals leave after a few hours and nobody dies. You've done a really, really good job, and that is very successful, and you can measure it that way. And you'll be able to see people who stop using other services at a high degree, jail bookings go down, that whole system. And then ideally, people become re-engaged. And the last thing I'll say, and then we'll go to Q&A, is that many of the individuals that one serves in a sobering center are individuals who are disenfranchised from so many other services. And just because it looks like they went to the emergency department 22 times to 140 times in a year, they're not actually connected to people. They are living outside most likely. They have lost most of their friends and family, and their community support and network is limited at the moment. But it can get better. But what happens is many of these individuals need a connection and need support to reintegrate into society and to reintegrate into them feeling their own worth and becoming like going into treatment or going into recovery services or whatnot, and then looking at how they can engage with folks. So there's so many different ways to measure, and that could be client satisfaction, people who refer parties in, and they'll also see the changes in these individuals that you're serving, and you'll kind of see a win from there. I can talk about this forever, but I'm going to wrap it up. And I think the next slide's the end, and we are going to Q&A.
Awesome. Thanks so much, Shannon. That was a great primer. So I'm going to just quickly revisit how folks can participate in today's office hours. You have a few ways to submit your questions. The first is in writing using the Q&A icon at the bottom of your screen. The second is verbally, so just raise your virtual hand and we'll unmute you. And then if you're audio only today, you've just joined by phone, you can email your question to my colleague Amanda at abank@chcs.org. And of course, feel free to use the chat function as folks see fit. Um, so, Karen, I love that you're already participating in the chat because I was just about to ask your question that you submitted during registration. So I think that what I'll do is I'll combine, while they're different questions, I'm going to combine them. And Karen, I'll also unmute your line in case you want to add any context to your question. So first I'll read it and then I'm going to come and unmute you. So Karen asked, Karen indicated in registration that they are considering starting a sobering care program at their organization, Caritas. And their question was, is there a place for social sobering centers that are not medically monitored? So that's the first question, Shannon. And then the second question that I saw from Karen in the chat are sobering services Medicaid reimbursable? And Karen, you should be able to talk now to the extent you want to add any context about your questions or your organization for Shannon.
I saw you unmuted, but I didn't hear a voice. So I can give you a second if you'd like, or I can start launching in. All right, I'm going to assume
I say
that
go
she
for it,
can't.
Shannon.
Back.
Yeah.
We're going to go for it. I almost muted myself just now. I was like, you don't need that. So, so talking about we'll start with the staffing part of it first. Excellent. Okay, thanks, Karen. So there is for sobering centers, the question around not doing medical monitoring. First is to confirm, so sobering centers aren't like social versus medical in terms of the naming. I know that's a detox thing that sometimes gets pulled over into the sobering world. So to answer the question, as I mentioned earlier, I said EMTs, I'd say at minimum, like a fabulous model is an EMT basic and pure professionals for a variety of levels on that. The question around whether or not you want medical staffing is really, there's a couple different considerations. First would be who the primary populations you think you're going to be serving. Are you looking primarily at, you're trying to divert from the ED and you want emergency department, you want folks to come from the ambulances. Definitely need medical monitoring for that, at least in the United States. I do have an article out of Toronto, Canada, where they are running a program that diverts directly from the emergency department, directly from ambulances that don't have to go to the ED. They do not have medical staffing, but it's different, I believe, in Canada than it is in the United States. If you're going to take from ambulances, 100%. Pretty much, if you're going to take from any populations outside of law enforcement and street outreach teams, so not necessarily street medical, but street outreach teams, you could potentially do non-medical staffing. High level of empowerment for the individuals on site to be first aid trained, full training on CPR, AEDs, et cetera. Very rare, like anything like that will happen, but they should be ready just in case. Alcohol intoxication, drug intoxication can hide many different things. The populations being referred themselves, if you're looking at a lot of young individuals who are doing one big night of heavy drinking, binge drinking per se, I would say yes, medical staffing. The risk for alcohol poisoning is pretty high. The risk for other types of conditions, such as they get too hot, the body can't regulate temperature, and that might not be as obvious to someone who is not a medical professional. And so there's like, I lean towards medical. Again, I'm biased, I'm a nurse. But then looking what the staffing alternatives are. If you're diverting from law enforcement, for example, and the jail doesn't have any medical professionals at all, and they're generally able to keep people alive in there, then maybe mirror it off of what they already have with existing services, so officers feel comfortable dropping off to you. And then just see if it's an obsolete model of care, like what's currently existing, you wouldn't do in this day and age, I'd avoid it. Err on the side of caution. EMTs and some other medical professionals are very inexpensive, relatively speaking. It's very economical. And then also start looking at cost avoidance. I won't dive into that because I could spend 20 minutes. Second part of the question is the Medicaid reimbursement. In California, yes. So California has sobering centers designated as an in lieu of service, which provides for Medicaid reimbursement. It is arranged on a county level between the healthcare plans and managed care organizations in a county, coordinate with the funders typically of the sobering center. That could be the county and or the CBO, the community-based organization itself that is running the sobering center. There's a variety of different ways to do the reimbursement. So it could go to the sobering center itself. It could go to the funder, such as the county behavioral health department. So it does work there. I know of other states that are looking at it. We are really hoping that it'll advance. One of the reasons we think behind that, this year I mentioned an accreditation program through CARF International, which some of you know. I don't work for CARF or anything. They have the very first sobering care accreditation program, was published out in January, launches officially in July. We are hoping that as accreditation becomes available, and now this offers a way to standardize and designate a sobering center, that we will be able to see more communities and more states be willing to provide reimbursement for a service that now can reach a national accreditation level. So I will stop there.
Thanks so much, Shannon. So we've gotten like a bunch of questions from the audience. Two questions from Jacqueline Quinones. Jacqueline, thanks for your question. And her questions are around the types of people that sobering center, asking about the types of people and their needs that sobering centers could or should accept. So the two questions are, like, do sobering centers also accept people who are at risk of suicide? And do sobering centers accept pregnant and parenting individuals that are in crisis? So I'm wondering, Shannon, if you can reflect on like those two populations, but also just in general about inclusion or exclusion criteria for folks coming to sobering.
Yes, and those are two excellent questions and two very high risk populations. But so thank you, Jacqueline. With I'll start with the first one. With individuals at risk of suicide, yes, 100%. Because often people are expressing the desire for self-harm potentially. Now, there is a caveat to that, is if someone is, maybe they're verbalizing some level of suicidal ideation or plan thereof, if they are able to contract for safety, and your facility, like most sobering centers are, is an open style where there's like eyes on everybody 24/7. Like you can see the staff that are there. There is a staff member at all times who can see every individual in the sobering center. Sometimes some have cameras because there's always a little quirky corner there. If that is the case, the person is able to contract for safety and they haven't attempted anything yet. They were not in the active pursuit of a suicide when they were picked up and brought to you. Then they would be, yes, I would accept that individual if you feel confident your staff can do that. And there are protocols around this, we can share them. For pregnancy and pregnant women, that one is a little bit trickier. If the individual is, obviously and everything's based on protocol, and we have samples of all these. If the person actively shows and they're highly intoxicated, most likely, if the person's coming from a non-medical referring party, so a street outreach worker bringing somebody in, they're like, this is the only place I could get her to go, 100% take that individual who is pregnant, and then maybe you can get them to the emergency department, because if they're that intoxicated, we really want to make sure that both the woman and the baby are okay on that. If they're not showing and they say they're pregnant, we can have conversation around it as long as they're not having any signs and symptoms of a challenge to the pregnancy itself. They would be able to remain in the sobering center. I really base it on the staffing, but in making sure that the woman isn't having, or the pregnant individual is not having any challenges to that. And hopefully that helps answer your question. And you mentioned the other populations. Basically, for criteria for folks going into the sobering center, the main criteria are that they are typically 18 and older. There are a couple of sobering centers that take 16 and older, but 18 years and older as an adult. No obvious medical need where they're stating pain that is something that they need to go to the emergency department for. There's other medical needs going on, or that you think might be happening. Non-aggressive in terms of nonviolent. They can be de-escalated verbally. So someone can have a conversation with them, they're able to relax a little bit and hang out. Those be the basic criteria of someone coming to a sobering center. They don't necessarily need to show ID. They don't necessarily need to give you their birth date. Ideally, they participate in vital signs if you take them. But if they're talking and they're walking and they're moving around, they obviously get a heartbeat and things are happening. So we try to keep it as low barrier as possible. They do not need to show insurance. And I'd say a lot of the individuals who come, it depends on the community, are in sobering centers that are in very high active, a lot of mass event cities. Austin, for example, you'll get a lot of individuals who are doing that Friday night out with their friends, Tuesday night out for the parade, etc. Then a lot of individuals you'll see, in particular, the people who visit more than once or twice, are individuals potentially experiencing homelessness or housing instability, and who are coming into the sobering center that way. And that has a lot of different variety of what the needs are of the individual, which also influences staffing, but also. Okay.
That's great. Thanks, Shannon. So we're getting great questions today. Thanks everyone for your participation and thoughtful questions. So there's a question from Hannah Zellman, who's asking, can heat/cold weather emergency centers be co-located with sobering centers? And how have neighborhood responded to sobering centers? So I'm wondering if you want to speak to the first question, Shannon, but also speak to NIMBYism and how you address that in communities.
Yes. So yes, you can definitely co-locate the heat cold centers with sobering, like during particular times of the day. It works particular times of the year, for example. So there's the winter storm time, the summer monsoon time, etc. We want to make sure that ideally there's some level of where every single person who's there has their own space. So if they're there for warming, heating, they've got their own designated chair, they've got their own designated bed. Same thing with sobering. We just want to make sure that everyone has their own space, because it just gets convoluted. As if for folks who've worked in sobering centers, I think there's probably a few in the room. It's a different type of engagement. Like lots of times people come and sleep if they're like on alcohol or opiates or whatnot. When you get folks in for heating, warming, or cooling, they're often moving around a lot. So it throws off the milieu a little bit, but it can work. I would say if there's ideal type of separation, especially when folks are intoxicated, there might be levels of privacy that are needed more than the average individual. Like if their clothes are all wet, you're trying to get them undressed to get them into a pair of sweatpants. You don't want that happening in the room in front of everybody. That's a general, and hopefully that. And then the second part of the question, because it just jumped off my
Oh, the
Q&A.
second part of the question was
Oh,
about
have
like how
neighborhood.
communities have responded to sobering centers. And and yeah, like can I just build on that? Like how do you get
Please.
ahead of NIMBYism when you're developing a sobering center?
Yeah, it's so NIMBYism, as I mentioned earlier, but for those who just came into the not in my backyard, there's the alternate YIMBY, which is yes in my backyard, of folks who are trying to get more services into their communities. Find a YIMBY if you've got them. So the response has been different. I would say if I had to sway, overwhelmingly negative, because they are conflated with shelters for individuals experiencing homelessness, who, which oftentimes, for example, many shelters, and not everywhere, but historically, it's been an area where there's a shelter for individuals experiencing homelessness. A lot of people camp outside because there's not enough space, and there's lines all day of people trying to wait in line to get in a bed. And this is what gets envisioned when someone says sobering center, they're anticipating this. And that's not what happens with sobering centers. So there aren't lines of people waiting to get in. That's not how the program works. From very extreme there's a particular county in California that was fully funded with the Whole Person Care Act to open a sobering center. And I think it was going to come with 3 years of funding to actually operate it. They never were able to get past NIMBYism and never opened the sobering center. This was 10 years ago, I'd say. It was around the 2015-16 days. And they never made it past it. And that I was actively working with them, I wasn't paid, I was just trying to help. I've gone to meetings in other cities where I've been spit on by people because they're so offended that we would put a sobering center in their community. I had another or another community flew 18 community members to visit San Francisco Sobering while I was there. And I brought literally the little old lady who's living across the street from where they wanted to put the Sobering Center in. With that, and so that's kind of segueing into, Meryl, what you were mentioning earlier is the idea around how do you engage them quickly? Getting champions in the community who understand or are willing to have a conversation around what we think is like, this is why I think a sobering center will help. Respite crisis receiving centers, street medicines, there's a variety of services that work with individuals who are highly stigmatized. Why we think, and then we have to be really curious around what they think are the needs in their community, what they have as what the real trouble is. Is what's going on in their neighborhood, in their community, the amount of drug dealing that's near a school? Is it a lot of people sleeping on the street? Is it just signs of individuals who don't have access to hygiene facilities that's left around the community? Where is the actual kind of challenge and how can you help each other out? And in terms of where the Sobering Center fills a gap and having real conversations around, is this going to solve all the problems? No. And this is what it can help bring to the community. These are phone numbers. Maybe they're like, we want to make sure, one of the things we had, and I'll probably stop after this, is one of the things I hear a lot, in addition to the standing in line, is now, if I have a sobering center in my community, everyone else in the city, the county, whatever, who's intoxicated is now going to be dumped in my neighborhood and not be able to get out because they don't have a car there with them. They don't have access. So that would be a concern. And that was something that a lot of sobering centers have their own van or car, so that when individuals are done sobering, they can bring them to public transportation, or they locate it near other services where there's an active bus line, there's an active subway, or there's some other transport program that can work with them to help get individuals out of the community. Finding that champion and a couple people who are like, I am excited about sobering and we have to meet at the middle, that would be the most helpful. It's not perfect. I wish it was. So
Thanks, Shannon. And that was a great question. So there's another question here from Cheryl Young. Cheryl, thanks for this. Cheryl is asking, what is the best practice when you have a sobering walk-in the middle of the night that does not meet your facility's criteria? And they're wondering what are the best referral options to give to that individual, or how do you handle that?
I love that question because that happens all the time. First off, make sure or do the best you can so that your middle of the night staff feel empowered to make decisions and feel empowered and feel that they are safe and the clients are safe. So whatever that happens to be, doors that lock or good lighting, or an entryway that has a door that separates the rest of the sobering. And that way, they're more likely to engage with individuals. Typically, what I have personally done while working in the sobering center on nights, and what I know a lot of people do, if the person doesn't meet criteria, but they are engageable and they don't seem to be someone at the moment, they're not trying to harm anybody. Oftentimes, the weather's not great. I almost cursed. I'm really going to try not to. I might let them in, and like, if we're give them a chair at minimum, even if we're a little crowded, and basically have a conversation of like, who are you? Where'd you come from? Why'd you show up at us at 2 a.m. when there's all these other potential resources going on? And just engage with them in that moment. If the staff feel okay with that, I would usually let that individual in, and then ideally refer them to other resources. If it's bad weather, definitely let them in and then figure out another option. If it's something where it's happening constantly, 2 or 3 or 4 people a night are showing up, now we got to figure out how to do a poster outside your door. What'll end up happening sometimes, I segued, sorry, now I'm back to my original point. So that individual I just engaged with, they spent the night, whatnot, left in the morning. They come back the next night because like, that was easy. Then at that point, I'd be like, okay, wait, we had this conversation last night. We are not a walk-in type facility. Let's troubleshoot some other things. Most of the time, it can be done without any challenge whatsoever. But it would be having the conversation with the individual, what their wants and needs are, and working with them. Ideally, we want to keep everybody safe. So if it's something where they're trying to kick in the door, I've seen that happen before or heard about it at programs. You can't help what someone's going to do on the outside. Hopefully your building is safe enough. It doesn't happen very often at all. In thousands and thousands of encounters I've dealt with, we've had aggressive things like that happen a handful of times. over the many years. So that's what I would do. I would just work with the individual, be nice to them. Worst comes to worst, they tell their friends that the sobering center was amazing. Next time they're intoxicated, they can go there. So yeah.
Thanks, Shannon, and thanks, Cheryl, for that question. So I'm going to pivot us to one of the one of the questions that were submitted during registration. So this question was asked by a few people, Eric Gray, Jacqueline Gallant, who I see. Jacqueline, you're on the line to the extent you want us to unmute you to provide context, and then Fiji Simmons. So the questions were all about like how or where do you get funding to start and or support a sobering center, and like what does sustainability look like for a sobering care program? And so I'm wondering if you can talk a little bit about that, Shannon.
Yes, and this is probably one of the biggest questions, and it is the most precarious at the moment, I would say. I wish I could say sobering was perfectly sustainable. It's obviously not. It is a very, very nuanced program. So a couple of the challenges I'll start with first. A couple of the challenges with sobering is oftentimes the funding mechanism, the folks who are funding it may not necessarily be the ones who are benefiting from the services themselves. So you've got a budget from the general fund from the county that is paying for it, but the budget for the jail is actually a different budget, and maybe they're the ones who are saving money, or the emergency department is saving money. That's a whole other different bucket. And so lots of folks will be like, well, I don't want to pay for something unless I'm getting the direct benefit of it. But then getting the sheriff's department, there are many sheriff departments who have funded sobering centers or been partial funding. Santa Cruz, California, one of the most popular ones right now. And so having that mix match of not being able to see a return of investment necessarily for the organization that's funding has been a challenge. And then the second thing, a lot of people don't know what sobering centers are. So a lot of folks are wary of funding it because they don't know enough about it. So for sobering centers in general, we've looked at them across the country. And when chatting with folks, most have braided funding. So they've taken funding from at least two different options up to 5 or 6 different funding partners. Vast majority level of city or county funding. State funding has become more popular, and everything from prevention framework grants, so things around trying to efforts to reduce substance misuse, areas of trying to do more prevention. Because if you have an individual who doesn't really have an alcohol or substance use disorder yet, but they're just starting to get more intoxicated and they show up at a sobering center the first time, that level of engagement and can literally change the trajectory of their drinking or use career. So opiate response grants are on the state level. And then looking at like the city counties, law enforcement and sheriff's offices, behavioral health departments, Department of Health Services, or public health departments, depending on how the county city is run. And then lots of times there's county or state level propositions that one can look into, such as tax revenues or bonds that are aimed at public safety, crisis management, the criminal justice reform, areas that we're like trying to get folks into we're either trying to get people into other resources. So they're trying to get folks into recovery and treatment services or into housing resources, but they need a door, and sobering is that door to get people out, to help get people into those services. 2 other ones are just diverting them from other agencies. So that would be one that is like, it really is keeping in mind braided funding. Every additional partner at the table creates more administrative burden to the agency that's running it. A couple things I'll say in part of this. I would love everyone to get on similar pages to what the outcomes that one is measuring. If every single funder is asking for an entirely different report all the time, that is not going to be the easiest thing. And the nonprofit literally will be spending so much of their time. I say nonprofit, the CBO, whoever's running the program, is going to spend so much time putting together reports and data for every different organization that it takes a lot of time. Try to get on the same page of what it is. I have recommendations if folks want to know. National Sobering Collaborative has it. The building blueprint here that we have linked has some data information in there. Then lastly, the reimbursement side of things. Sobering centers probably will never be a in the black agency in terms of like you're having all these visits for individuals coming for sobering and then you're getting reimbursed for it and it breaks even. I can imagine that will probably never happen unless you have a very high percent population of individuals who are Medicaid funded, specifically if that's the only reimbursement, who are coming to the Sobering Center. You're going to get folks who don't have any type of insurance that are coming to the insurance, who have Kaiser, who have Blue Cross Blue Shield, who are coming into the Sobering Center because you're not restricting based on insurance. And I would say if you do decide, well, then let's restrict and not let people in who don't have Medicaid. The referring partners will not bring to your sobering center. They are not going to spend the time in the field making sure they have active Medicaid before they can drop them off at jail. They can bring them to the ED instead. So we want it like it's that weighing the differences. And that's where I think the braided come in. Reimbursements come in to supplement some of it. And then the costs for the other groups who are paying for it do go down. Hopefully that makes sense. And feel free to hop in and ask more.
Yeah, definitely drop any additional questions on this topic for Shannon in the chat or Q&A icon. Um, I want to switch to a question that Nancy Bem submitted. So Nancy's a project director of Rooted Life in California, and they indicated that they're considering starting a sobering center program. So Nancy, I'm going to ask your question, but I'm actually going to unmute you just so you could provide a little bit more context for Shannon to the extent you are able to speak. So Nancy asked, how are agencies ensuring that they get participants, I assume that's folks, to the sobering center. And Nancy noted that the sheriff and police are struggling to refer due to required medical triage. And Nancy, we're just wondering if you can elaborate more on that requirement.
Hi again. Thanks for the space. It doesn't hurt to ask this question again. So, yeah, in San Diego County, from our understanding, there are a lot of hiccups with entities becoming sobering centers because of the need for medical triage at the point of like if someone were to come to a sobering center and bring somebody, they would need to be triaged by like an EMT or a nurse or some sort of thing. Like, and that's a huge financial burden to bring to this kind of model. And so it sounds like this, from my understanding, the sheriff doesn't believe they can bring people unless those medical personnel are present, if that helps.
I know what you're talking about. Okay, so this is driving me crazy. So there are a couple different things happening, and this is a thing that California in particular has been struggling with. So there, for individuals, so across the country, sobering centers, law enforcement, street teams, etc. There is no medical triage that is required, including in California. There is no medical triage that is required in the field before you bring someone to a sobering center. Law enforcement can pick somebody up. They're nonviolent. They don't have any standing warrants. They weren't in the process of committing a felony while they were intoxicated. They pick them up, they put them in their cruiser, and they bring you over to the sobering center. No medical need, no medical assessments, no medical triage needed. For a paramedic, this is a different beast. Paramedics do their own triage on the field. That's part of their job. And they will figure out, like, do they meet all the criteria? We have fabulous criteria have been established for ambulances between a few different cities that take them from them, and they're out and available to be shared. They do their triage and then they decide, here's the algorithm to send someone to sobering. Do they match it or not? Yes, great. And the person wants to go, bring them to sobering. Otherwise, bring them to the emergency department or leave in the field as the other alternative for EMS. What has happened, I think, Nancy, and this is I'm assuming has happened in California, is I'm hearing this a lot. There is a second bill that has been going through legislature, and one, it was the fifth one. We passed it in 2020, which is AB 1544, which stipulates ambulances in particular going to a sobering center in California. And it's basically, it's a stipulation, it's a bill that talks around ambulances being able to go to any alternate destination, urgent care, sobering center, what's the other one I'm thinking of? Oh, mental health crisis center. And it's all about that. And it talks about inside of it that the sobering centers must have a registered nurse on staff in order to receive those individuals. And so there could be the confusion. It might not be. But I started by saying they don't need to do any medical triage in the field. Excellent. If this is the confusion, it's the ambulances that do in triage. And the ambulances in California only are required to go to a registered nurse or higher level of staffing. In other states, they don't have that same criteria. They just have to go to an equivalent or higher level of staffing. Shout out to the Austin Sobering Center, which opened about 5-7 years ago. They are staffed by paramedics. And so the EMT paramedics are the ones who staff the Sobering Center and take directly. We have Albuquerque has licensed vocational nurses, in addition to EMTs on staff and an RN and a nurse practitioner who work regular hours, like Monday through Friday type situation. And so there is a variety of level of staffing. So let's say that for law enforcement, basically the person 18 and older, verbally responsive, they agreed to go. Excellent. And then yes, and we can talk more too with the Sobering Center, like, and feel free to reach out because this is a question, especially with the California confusion that I've been doing. The one thing I did want to say, just as a side note to this one, because your question kind of leads to it, is even if there's no burden, like you mentioned, where there's confusion around the triage, for across Sobering Centers, anywhere, any community that's ever started them, there's a whole bunch of people who are at the door ahead of time. They're in the meetings. They're like, this is the greatest thing that's ever going to happen. Every officer is going to be going there. Every EMT is going to be driving there. We're going to fill that place up 2 seconds after it opens. I did see that happen in one city, Washington, D.C., when they opened. I mean, I literally visited 12 hours after they opened and they were on their 14th patient. I was like, wow, that was a record. Shout out to D.C. And the cultural change that is required to get someone to change from their current practice in the first responder world, it's not easy because people are like, one, they could just be used to the system. 2, you can bring someone to the emergency department, never go wrong bringing someone to the ED. So I might as well just keep doing that. Put them in jail, someone else gets to deal with it. So getting that cultural change is tough. I can dive into it more of interest to other folks. But basically, like, that's the type of things, like, you want to get leadership on board. And Nancy, maybe in the area that when you're in your community doing ride-alongs with the officers, get in there with some of the cars, ride along with the straight up frontline officers. Go with the supervisor once in a while too, it's fine. I actually did that in San Diego where one of the lieutenants brought me out and we drove around for a few hours to check out the area in San Diego. But they basically figure out, like, who do they think would go to a sobering center? What do they know about the sobering center? What do they think are barriers to it, et cetera? So I'm a big fan of doing ride-alongs and really talking to not just leadership in the meetings, but the frontline folks who are actually doing the transporting. Those are the people who will tell you, this is why I'm going or not going to the sobering center, or I wait, if I ever do or not. So that's stuff.
Thanks, Shannon and Nancy. So we have about 4 minutes, Shannon, and I'm gonna try and have us like do the impossible. Is that
We're gonna do it.
we have like 4 more questions, but I'm gonna try and group them so we can get to all of them. So the first questions are about managing substance use and also developing programs that align with the philosophy of harm reduction. So someone is asking, they're basically saying that there's a sobering center that does not have a medical team, which differs from another sobering center. And the major difference is that the one center uses their sobering center as a bridge to detox or residential treatment, which impacts who they accept, while the other sobering center has become more of like a one-night stay guarantee for participants. They're wondering which model is more preferable from a harm reduction perspective. So curious, like, if you want to reflect on that. And someone was also asking, like, is there a best practice for managing substance use inside the walls of the sobering center? And so I'm just curious how you think about the type of program and also managing substance use.
Yes. So I'm going to try to do this in 45 seconds. So I'm very familiar with the Exodus Recovery. Nice to meet you all from on the CRI-Help side of things. So the Sobering Center itself, one of the biggest benefits and the reason that Sobering Center works the way it does is it is no barriers. Anyone intoxicated, you come in the door. You do not have to agree to anything. It is the door. There's a fabulous, someone's called it once, Sobering Center is kind of like the front porch of a house. Like, come hang out in the front porch with me for a while, sit in the rocking chair, sober up a little bit, have a conversation, and then you can go back down the stairs and go about your way. Or look, we got a whole bunch of doors behind us. You can go into the house, you can go to treatment, you can go to other things. But everyone's welcome on the porch. That's sobering. It's brilliant. And you engage with individuals. And I see in the question you mentioned, like, yeah, someone could come in 250 times and never go anywhere else. substance use there's so many reasons behind it. The individuals who have that type of history of substance use often have, from very young age, their coping mechanisms are not to the degree that one would anticipate at someone's age, for example, and alcohol and or substance have become that coping mechanism. And there's all these other things, mental health behind it, their health things behind it, their day-to-day life, their friends, anything around it is surrounded around substances. You cannot go to treatment and expect all of that in the past to be taken care of in a session. So restricting people to sobering because they don't want to go someplace else, no. But they fill different roles. So that second one you mentioned of like bridging in, there are a couple programs, we're calling them, we've coined the phrase now, holdover beds. So sobering centers will designate a couple beds for exactly the individual you're talking about. They're ready. They're like, I want to go to detox. But it takes more than 4 hours to get them there. So now we hold them in the sobering holdover bed for a day and a half and then transfer them. Having sobering have some level of ability to hold over is amazing. Stop.
Thanks, Shannon. That's great. Yeah, and if folks want to follow up with us after, we're happy to chat further, and we'll also include responses to these questions in the FAQ. So the last question is around referrals. So folks are asking, one, how do you share information with potential clients about the Sobering Center, that it is available to them? And two, like when you're working with community referrals or other agencies that are not law enforcement, like should you share your screener with them so they're aware of the criteria? Should you have like a screener for them and then an internal screener? Should that be the same? There's lots of questions, I think you can see, Shannon, from the audience about the referral process.
Yes. So the referral process, excellent question, because the one nice thing with sobering is you ideally don't have different criteria necessarily based on the referring party itself. Like the street outreach team, the person would fit the same criteria, 18 and older, intoxicated on some level of substance, nonviolent, no obvious medical condition. That matches the same as law enforcement, same as the emergency department. And the reason I say emergency department, sometimes you have folks who have high levels of withdrawal that they go into it really easily. At that point, maybe eventually you'll have an individual, like if this client has been in the emergency department for more than 6 hours, let's talk about what the withdrawal looks like, because they will go into a seizure. Other than that, we take people all the time at sobering centers. Yes, and what I would do, rather than sharing your criteria, I wouldn't do that, but I do it in a format that's like, for sober living houses, someone resumes use one night, or a treatment program, they're in a 90-day program, they resume use one day, it's a trigger, whatever happened that day, they can come to the sobering center, sober up for a few hours and come back. I would have one pagers for them that basically say, this is how you refer, this is our standard criteria. That standard criteria is going to match everything. It should be simple. Like those ones I mentioned, I'm not joking when I just said those 4 things: 18 older, intoxicated, no other things. That's it. They don't have to do screeners. They don't have to do PHQ-9s. You don't have to do age surveys and audits and all these things to screen for substance use and mental health. They're intoxicated in the moment, but they seem safe, bring them on over. And have the right phone number for people to call. Shouldn't have to do too much work in addition to that. And ideally, the last one, sharing with the individuals who are potential sobering themselves. You can have quick flyers, postcards, the one shout out for referring parties that are in vehicles, like you mentioned, law enforcement, having little postcard size that they can stick on their dash that says this is how you bring someone to the sobering center, or wallet size, depending on what they carry for books on the teams, or something get taped to the back of the iPad if that's what they use, comes in very handy.
Thanks so much, Shannon. That was incredible. Really appreciate you taking the time to walk us through those questions. And thank you, everyone, for joining. I think we can pull the slides up, and I'm just going to quickly wrap us up before folks hop off. So as Shannon mentioned, and as we've been putting in the chat, there are a number of new publications like the Blueprint and the Budgeting Tool, as well as a few others like case studies about the Santa Cruz Sobering program. We encourage you to check those out. They're linked here on this slide. I've mentioned this already, but an FAQ is forthcoming that will detail responses to the questions asked and the questions that we didn't have time to get to during our office hours. An evaluation is going to pop up on your screen once you leave the webinar. We really would appreciate if you could take a moment to complete that evaluation. It helps us improve our work. Also, if this forum was helpful to you and you'd like to see more office hour type sessions, please let us know. Lastly, if you have any questions about sobering centers in California, feel free to reach out to Melora Simon at the California Healthcare Foundation, who is leading the foundation's work in this space. Again, thanks everyone for being here. Shannon, thank you so much, and I hope everyone has a good rest of their day. Take care.